All right, so it's 12 p.m. EST time, and here in São Paulo it's 2 o'clock. I think we can start. So, hello everybody. Thank you for joining us in another meeting from the Pan American Trauma Society. I don't know if Dr. Antonio is here, but I think he's going to join this session in a bit. Today we're going to have Dr. Evelyn Coile as a presenter. She's going to present a case about a traumatic gastroesophageal injury, and it's really, really interesting. She's from the UT Southwestern Texas Health Presbyterian Hospital, and I met Dr. Evelyn. Actually, it was, I think, maybe a couple of months ago, because Dr. Evelyn is part of the team that is working on the ultrasound for emergency and trauma course from the Pan American Trauma Society. So she's one of the doctors that is helping me with the English part of the course. So I'm very happy to have you here, Dr. Evelyn, today. I'm sure you're going to give us an excellent talk. And we are having Dr. Untracht, Dr. Kassim, Dr. Francisco Collet, and Dr. Edward Lenin as panelists today. So feel free to start whenever you're ready, Dr. Evelyn.
Okay, thank you guys for coming today and listening to this topic. We're going to go over traumatic gastroesophageal injury, and we're going to do it in the context of a really interesting case that I participated in as a first-year fellow last year over at Texas Health. I am a UT Southwestern second-year fellow and receive an excellent education. We have a couple of level 1 trauma centers that we participate with, and this was over at Texas Health. So just a thanks to Dr. Edmondson for allowing me to present this today. So I have no financial disclosures. Our objectives today, we'll kind of hit these as we go through the case, but the epidemiology of traumatic gastroesophageal injuries, the diagnostic difficulties of that type of injury pattern, and then the modern management options, and then the novel therapy that we utilize for this patient.
Dr. Coyle, I'm sorry.
Yeah.
I'm sorry to interrupt. Can you close this? There's a small window on the.
Yes, you can see that.
Yeah, we can see it. Maybe
So
I don't know if
sorry.
you can close
Ah,
this.
is that better?
No, it's still there.
Is it this window?
Yes.
Yes,
Okay.
it's the welcome to PowerPoint presenter coach window. Yep.
Oh no. Okay. Let's come out of it and try again. So sorry, guys.
No problem. No problem at all.
I do not claim to be the most technically.
Maybe if you, yeah, it's out
gone.
now. Yeah, maybe
Okay.
if you,
No,
yeah.
I'll get rid of it. Get rid of it. Oh no. Oh geez. Huh.
Maybe if you just click on that on the PowerPoint over on the right lower corner, probably it's going to disappear.
Okay.
Did it? No.
No.
There you are.
Yeah. Or maybe if, I don't know if you want
1
to.
second. Let me just
yeah.
stop share for just a second and come out of
Exactly.
it. And we'll see what we can come up with. Okay. Okay, my friends, thank you for your patience.
No worries.
We'll try again. Yeah. Is it better?
Yeah, it's perfect. Thank you.
Thank you so much for your patience. Okay, back to the meat. Okay, let's talk about the patient. All right, 39-year-old male. He presented with 5 gunshot wounds. It involved the epigastrum, and I want to be specific about this because this involved the box. It was just under the xiphoid. and within that costal margin. So we did consider this a gunshot wound to the box. He did have another injury to the left upper back on the roll, forearm ×2, and then a left heel. This was all the information that we received on the page. So what we got before he arrived to the trauma bay. His heart rate was 118, blood pressure was 138/108, GCS 15 en route. Pulse ox is 100%, but they were giving him 2 liters of nasal cannula support. They did apply a tourniquet en route. So this is all per the EMS paramedic acquired data. All right. And then when he got there, the patient did arrive diaphoretic. He was quite tachycardic to the 130s. He remained hypertensive throughout his trauma bay evaluation. His primary survey revealed the same gunshot wound pattern that was already described to us. We did not find any additional ballistic injuries. His chest x-ray I'll have on the next slide, but it was pretty unrevealing. On radiographic interpretation, they did have a questionable linear hypodensity. They thought maybe a pneumothorax. The abdominal x-ray is pertinent for this ballistic here in the right lower quadrant, which was quite perplexing considering his injury pattern. The tourniquet was removed. He did not have any significant bleeding to the left arm after that was removed. He had a negative EFAST. Only the left side of the chest was scanned on that extended fast. I do not have those images, but those were negative. The patient was intubated because he wasn't tolerating his pain very well. And just to control the situation, the patient was intubated. He did receive 2 units for the persistent tachycardia in the 130s, followed by NTP activation for planned operative exploration for penetrating injury to the box via ephemeral cordis. So at this point, if I was presenting this at Parkland, which is where I mostly operate, there would be a lot of contention about what our next step was. So I'm going to ask the panel of experts, where would you be next, OR or CT scan, if I told you that his heart rate did respond to the 2 units of blood and MTP?
I'm sorry. So the heart rate, the patient did respond, right?
Yes.
Okay. Dr. Untracht, do you want to start this one?
Yeah, so he got what, 2 units of whole blood, and that eliminated the tachycardia, and blood pressure remained stable, if I understand correctly. At that point, I'm guessing that you went to CT scan because he was a responder, assuming that he didn't quickly become tachycardic and hypotensive. You might have gone to CT scan. On the other hand, with this X-ray, I'm guessing that that's the bullet that entered via the box just near the Ziffy sternum. And you say that the chest X-ray was unremarkable, meaning you didn't see any other bullets on the chest. Oh, there it is. Okay, so entered the left back. It must be an exit wound somewhere. So there is a bullet that that went through into the abdomen. The other option is, if the abdomen on exam is not totally benign, to just take him to the OR, do a laparotomy with perhaps a subxiphoid window if you're not confident about the negative EFAST. But I'm guessing in this case that you took him to CAT scan.
All right, great. Dr. Lenin, do you want to add something?
I mean, I'm not that old, but you know, I'm getting there. But I mean, and I know people do it today, like go to CAT scan with MTP and things like that, but that's not something I would do. I don't know how it's going to really, honestly, change your management here too much. And I think it can be dangerous. And I would, you know, certain system traumas, wherever you are, have unique capabilities, and maybe wherever you're at is capable of doing that safely. But I think, you know, this guy would be in the operating room very quickly I would think.
Great. Dr. Kasim, any comments?
Well, when I see a patient like this with multiple gunshot wounds, and the question I always ask to myself, what is the probability that one of these gunshot wounds is going to kill him immediately if I don't take rapid action? And that's where I put my money. I would like to determine, looking at the patient and looking at this multiple injuries, and knowing that there is a wound near or at the box, and I would be concerned. I would be concerned that this may be where that his demise might come from, something that I have missed, not addressing what's happening in the box. Then when I look at the KUB of the abdomen, a bullet is lying in the right lower quadrant, and it probably is not where he was shot. It is traversed from somewhere to the right lower quadrant, and then I'm begin to think, is this bullet get carried away, or is it the trajectory? And if it get carried away, I would be suspicious that, this may be in the artery or the vein. So having said that, I agree with Dr. Lenine. I'm not one of those fellows who want to send the patient who is getting blood transfusion with multiple gunshot wounds to the CT scanner, because it's not really going to help me very much to know the CT scan shows that he has or a bullet in the abdomen. And as far as the chest is concerned, it looks okay, but I would be suspicious of, I would certainly do an ultrasound of the chest to see if there is any evidence of pneumothorax. If it is, at least I will decompress it with a needle and then get on to the operating room as quickly as possible. In the operating room, the first thing I would do would be to do a subxiphoid incision and open the pericardium to make sure that I'm not overlooking blood around the pericardium. And then, of course, I can extend my incision all the way down and look in the abdominal cavity to see what I can find and correct the problem. Thank you.
Great, thank you. Dr. Veron, do you have any comments regarding the intubation of these patients in the trauma bay that you can add for us in the meeting?
So I'm not a surgeon, but I would like to comment because we've seen these cases. I agree with Dr. Ontrak, and I agree with Dr. Lenine. That bullet seems to be in the abdomen. Unless you have good evidence that it's not there, let's say it's in the backboard or somewhere else, there's a bullet inside the abdomen. And even if the CT scan is negative, you may be able to, you may have a bowel injury. So that patient in our place will go for an exploration. So an ELAP and a pericardial window will be the way that we would go, basically. Comment on the line. Usually when somebody gets shot in the abdomen, that area, you should have lines above the diaphragm too. And I would have put a subclavian rather than a femoral line, because you don't know, if he has an IBC injury, it's just all going to bleed through that. And just a reminder, we haven't used cordis in a very long time. It's not their specialty anymore. So the appropriate term for that line, otherwise you can call it a teleflex line, because that's a company that makes them now. But it's better just to say a femoral venous introducer rather than a cordis. I bet you, Evelyn, you've never seen a cordis. I have seen the cordis. So that was it started, but now they still have some introducers, but that's not the ones that most people use. So that's the comment I have to make. Regarding securing the airway, it's going to depend. If the patient is conscious, the best place to do it is in the operating room, because there's a good chance that with the increased intrathoracic pressure, the patient may crash. So I would, as long as the patient, is a little bit of awake, we would probably do the intubation. And as you know, for penetrating injuries, time to the OR is what is the most important thing for prognosis. So, and unless we're waiting for something else, then we would intubate him and debate. But if not, this patient go to the OR, secure the airway, and proceed. Look in the abdomen, and if there's nothing there, then do a window. That.
Perfect. Thank you. And Dr. Coile, would you go to the OR directly, or would you try to get this patient to the CT scan before?
So I think me, right, Dr. Coile. So there's one thing that's a little bit perplexing. I tried to allude to it when I mentioned the ballistic in the abdomen. So we have a subxiphoid hole, and we have a just left of mid back hole. And then we have a right lower quadrant ballistic. And we also have a big scar on the abdomen.
So that
laparotomy.
bullet was there before. Is that what you're going to tell us?
Bullet was there before, tricked you. To kind of, or maybe it wasn't. So things didn't quite add up, and we definitely wanted to know where we should start. We definitely had an ultimate plan for laparotomy with a pericardial exploration, and that is what the patient ultimately ended up with. But since we did have such stability in blood pressure, with intubation, with line placement, with blood, and he was this responder, we did take the time to go get a quick CT. And we do have the benefit, particularly at this trauma center that I have a pleasure working with, they do run them through the CT quite quickly. So it was an in and out kind of situation. I was grateful that we had it for our operative plan, because that bullet is actually in the back of the patient from a prior gunshot wound. So anyway, I think ultimately this was a good decision, was to get the CT scan. It did help us just kind of focus on the foregut, which is where all of his injuries actually are. So I'll keep going here. Forgive me in the background here. I mentioned I wasn't technologically savvy, but this is the CT scan. It kind of runs through fast, but I'm going to try to pause it with the significant findings. So what you see here, I have it on a lung window as well, but you have a significant amount of hematoma in the left upper quadrant around the spleen and around the stomach. And then you have some distals of air that are kind of hard to appreciate. You see them better on the lung window, which I have on the next image, that are outside of the gastric wall, and it's very obvious. There's also a significant left hepatic lobe injury. So I'm going to let it play one more time. See if you guys, sorry, it's so fast. You guys appreciate that. And no ballistic in the actual abdomen. And then here, same thing, unfortunately. But I'm gonna pause it. Nothing in the chest. There's no hemopericardium. But you'll see a bunch of little distals of air kind of around the stomach wall there. Once it plays through again. You see, tiny. But they did call a grade 1 spleen injury, a grade 4 left hepatic lobe injury, and then a concern for a gastric injury were the CT findings from this abdomen. No change, at least from our operative plan from the beginning, but at least now we're not so concerned about that ballistic that was kind of perplexing.
But I would say, did it change your management?
No, we still had the plan to do an X-lap with a pericardial window, but we did at least kind of start with a pericardial window.
And where are the bullets?
So there's a ballistic wound subxiphoid and one on the left mid upper back.
No, but where they don't show on the CT scan as far as I can
I
tell.
think it's
There's
in
no
and out.
retained.
Sorry?
It went
There's
through the
no-
subxiphoid and out the left back.
Yeah. All right. So we did exploratory laparotomy with a pericardial window. The pericardial window was negative, consistent with our FAST exam. We did also place a left chest tube because of that interpretation that was called into the OR of a tiny pneumothorax. There was nothing that was a negative chest tube placement. There was a hilar splenic injury. The patient received a splenectomy for that, a tiny transverse colon injury that was primarily repaired with a colorraphy. There were significant gastric injuries here. So there was 2 gastric injuries, one anteriorly along the fundus and one posteriorly. It was managed with just a wedge resection with a blue load stapler. And then there was a 1 centimeter defect to the gastroesophageal junction there. And this is what kind of causes a lot of trouble for our patient. This was initially repaired with a 2-layer repair utilizing vibral stitches. The left hepatic lobe grade 4 injury was managed with packing, and the patient was left open for a second look the next day, considering the bleeding from the liver.
Can I ask you one question?
Mhm.
You said there's 2 holes in the stomach and 1 hole at the G junction.
Mhm.
Shouldn't the holes, we usually expect like there to be an even amount of holes in something. So
Yeah.
was there a worry that you were missing a hole somewhere? Or I don't.
Did not seem to be that way from at least
When
the multiple explorations the patient received on index or on return to OR the next day. But so far, that's what he had. I see what you mean, but it also, banged up the liver there. So
okay.
And Dr. Ginsburg, he asked a question in the chat. So he's asking why not performing a chest tube for diagnostics, and if negative, going straight to the OR instead of a CT scan. So previously.
fair. Yeah, that's a fair assessment. I think if you have, for me, I think if I have a negative pericardial window on my FAST and I decide to place a chest tube, to me, I've thoroughly investigated the mediastinum. In my hands, that would be it. I don't know if I would do a pericardial window after that. Does anyone else feel differently about that?
Dr. Untracht.
No, I think that's reasonable.
Okay. Dr. Kassim, Dr. Francisco Coile.
I don't trust that, and I would certainly do a pericardial window because I like to sleep at night safely.
Dr. Francisco Coile, what about you?
I think the pericardial window is very safe for in this situation. I know that sometimes he cannot see blood in the pericardium. Sometimes it's difficult to see in this with these small injuries or small place. So I think it's correct to start with the pericardial window. And I know that the problem is the injury. We have left lung injuries, grade 4. Is sometimes difficult because in this position, the blood can cross the inferior vena cava through the caudate lobe. It's very near the pericardial, the junction of the jejunal tissue. Junction sometimes very difficult to approach in this situation. And you have, in this situation, you have left diaphragmatic vessels who run over the esophagus in this position. Sometimes maybe injury, maybe some blending comes from the vena cava injuries or hepatic injuries. So sometimes blending too much in this situation. I think it's very difficult sometimes when you treat the junction. Sometimes you can use for correct disease, you can close the holes, but sometimes you can put a valve missing, gastroesophageal. I don't know the correct terms either. To correct gastroesophageal reflux. So can be a missing or a link to close the hole in the esophagus in this position. It be more safe to avoid fistula that can be appeared in the postoperative. Sometimes very important in this situation. I think in these situations, when we have these injuries, a possible injuries, the CT can be helpful to make, if the patients permit, you can permit you to have a CT, you can study the case and correct approach in these injuries. Sometimes injuries on the vena cava may be tamponate, sometimes you can be suspected by the CT and can avoid to explore acutely during the laparotomy. When you go to the laparotomy, you can sometimes go to see the hematoma and can make more injuries than the need. So I think sometimes if you have a CT, you can be useful if the patients permit to do the exam. If not permit to do the exam and you don't have CT, you have to go to a laparotomy. Okay? But I think it's very important in these injuries how to prevent this gastroesophageal jejunal hole, how to prevent fistula and the postoperative. And sometimes it's interesting to sometimes use jejunostomy or gastrostomy or nasoenteral tube for reanimatation of the patient in this procedure. Sometimes important to discuss.
Great. That's a good point. We're going to talk about a little bit of the management as well. I just want to highlight another comment from Dr. Ginsburg, and that when he said that ultrasound with hemothorax is not as accurate as if you don't have the hemothorax. And it's a great point because sometimes we got a little bit confused getting a negative test in a patient with a hemothorax, and we need to remind ourselves that this situation is not may not be accurate. And the same Dr. Tanya Zachrison, she also stressed this out, and especially with gunshot wounds because of the defect size in the pericardial sac due to the gunshot wound. So that's a very interesting reminder as well. Dr. Evelyn, I think you can move on, and we are very, very interested in seeing what you did.
All right. So the patient, as I mentioned, was left open and transferred to the ICU where the patient did well overnight. No significant blood loss from the Athera wound vac system and required no additional blood products, was appropriate to return to the OR the next day. The next day, considering the extensive gastric injuries, the performing surgeon decided to place a jejunostomy feeding tube in a Witzel fashion. Drains were placed along within the lesser sac and within or anterior to the injury as well, within the gastroesophageal injury, I should say. And then a mental patch was also placed. The patient had extensive omentum, so a nice little patch was placed up there, tongue of omentum. And then an NG tube remained. The patient was able to be extubated after the OR this time. Is there anything else you guys would have added?
So just to
Can
be
I
clear.
ask a question?
Oh, yeah, sure, Dr. Kassim.
So could you please tell us the index surgery? What exactly did you do to the G junction area? Did you just oversew it, or did you do something fancy?
So the area was debrided and it was repaired in a 2-layer fashion with vicryl stitches. The only thing that was added on the return to OR the next day was the omental patch.
Omental patch.
And the
Okay.
drain. And of course, knowing that this was going to be quite a tenuous area, the jejunostomy tube was placed for feeding access.
It's a good idea to do a jejunostomy as opposed to gastrostomy. In fact, you should avoid doing a gastrostomy in case you're going to do a pull-up of the stomach as a conduit later on if something doesn't work. So utilizing the jejunum as a feeding conduit, it's a very, very good idea.
Excellent. Dr. Untracht, any comments on that?
No, I'm just curious where on the esophagus was the repair? Was it the medial surface, along the lesser curve, or at the notch on the left lateral side, anterior posterior? Because it seems like this is one bullet went through and made all the two wounds in the fundus and then the tangential wound in the esophagus. But where exactly was this wound?
You'll see some pictures later, but just distal to the Z line. So just right at the Z line.
And
Very
Z
distal.
line, you mean what by that? That's after my time, I think.
I'm trying to think of another way to explain the Z line.
Z-line is an area where the mucosa color changes between the esophagus and the stomach.
Okay, but
And
that's
it's a transition zone.
yeah,
Mhm.
okay, but that's the 360 degrees. I mean, where was it?
Anterior.
Oh, anterior. Okay. Right.
Yes, sir. Yeah.
Yes. Right. Well, I'm just curious why at the initial operation or the second operation, the repair of the G junction wasn't reinforced with a fundal wrap. Were the injuries just too extensive to use the fundus, or?
Well, he had received a stapled wedge resection of the fundus. So at that point
Was enough? Okay.
wasn't amenable.
Dr. Lenny, any comments on that?
No, I mean, obviously I would try to see if we could do something to mobilize the stomach, and wrap it. Especially after a splenectomy, stomach's pretty mobile, get some up there. The other thing we often do with people who are we suspect probably gonna have some problems feeding is, these jejunostomy tubes can cause problems. Especially when the patients are gonna be sick and everything. So a lot of times we just tack a limb up to the abdominal wall with clips so that we let them heal a little bit, and then you can stick it with fluoroscopy later after it's sealed. Because sometimes these people end up being sick, they're leaking, and the jejunostomy tubes ends up being the problem.
I see. Interesting. Okay, Dr. Evelyn, I think you can move on.
So it's almost like you have a crystal ball, because within 6 days, this patient did sustain a leak. And, this is an interesting point because there's a lot of various literature, and I think the time to a GI study or contrast to CT, whatever your preference, to evaluate your repair of a gastroesophageal repair, or even if you're repairing an ulcer, that time is kind of variable, but there's not a lot of trauma literature about this. So we decided to study at day 6, which is probably much delayed, what most people would do nowadays. But day 6, he has this leak. He also has a small bowel obstruction, and it was because of our jejunostomy tube. So the Wetzel kind of caused a little bit of a kink. It's hard to describe, but he had on that previous exploratory laparotomy a small bowel anastomosis that was just a little bit distal to where we placed our jejunostomy tube, and really would have required some better planning for us to avoid this complication. So both small bowel obstruction and leak, one can estimate that maybe the small bowel obstruction contributed to our leak. The NG tube was always to suction, of course, but I hope that this was not associated, but I have definitely lost a lot of nights sleep about this, that maybe they were correlated. But anyway, we have a leak at this point. We definitely returned to the OR at that point. He had the jejunostomy tube resected, that portion of the bowel resected and redone. And then he did have a gastrostomy tube placed at that time, because he really was angry about the NG tube. So, and knowing that he would need continued gastric decompression, we did place a G tube at that time. So luckily his drains were in a good spot and they were managing his leak quite well. He was not sick at this time other than his bowel obstruction.
And where did you put the gastrostomy tube? Did you use any specific points in the stomach, considering the need to? Yeah,
just anterior, no different than a traditional G tube. We did not anticipate needing to use the stomach as a conduit. So I guess the management of the leak would be the next topic. Beyond just the gastric decompression, what would you guys do?
Yeah, exactly. Dr. Lenin, do you want to tackle this one?
I mean, this is a small leak. I mean, if it's well drained, there's options and the patient's not septic. So, I mean, you could just wait it out. A lot of them will close, especially if you treat your bowel obstruction, nutrition. And then there's the option of endovascular treatments, which obviously isn't my specialty, but you know, there's clips and stents and things like that. And they're, you know, they all come with their risks and their kind of problems, but you know, they've worked out pretty well in the, you know, for perforations, like non-traumatic perforations. So I mean, those are an option here. You have to find obviously someone who's somewhat willing to take these things on though, because they often come with maintenance, you know, the endoscopic maintenance.
Yeah. Dr. Kassim?
In my experience, when I see an injury to the GE junction like that, I always resort to the idea of doing a fundal plication of that area, if I can get that done. In this case, because the fundus was resected, technically it would have been impossible. But then having said that, esophageal repair with 1 layer, 2 layer, they are fraught with possibility of a leak. You know, the only person who didn't have any leaks like that would be a gentleman called Ronald Belzy, the famous Belzy repair. He told me when I was at Bristol in his hospital, he has never had a leak. Well, apparently that was quite true. He never had a leak, but we are not all Belzy. So now that you have something like this, I think you have to take the bull by the horn and you've got to fix this, because this could turn out to be his Waterloo. And I don't like just temporizing measures like, you know, draining it and leaving it alone and all that. I've never been very happy with the outcome of procedures like that. And the other thing, like Dr. Lenin says, distal obstruction must be resolved. If the distal obstruction persists, no amount of surgical maneuvers, therapies, etc., will heal the proximal leak. So that's all I have to say. Thank you.
Great, thank you. Dr. Francisco Coile, you told us about some options to avoid these leakages. Now that Dr. Evelyn showed us there's a leak distally in the esophagus, what would you do?
I think it's very important in the first surgery, we can try to avoid these lesions. You can use the gastric wall to cover the shooting of the esophagus, using a lissing procedures or a lean procedures, or only put the stomach over the esophagus injuries. Sometimes it can helpful to not become this leak. For in this situation, if you can't do usually put drains to prevent a fistula in these injuries. Sometimes you have only suture, you can put drains, and to avoid the direction the fistula through the drain. Sometimes it's possible. If not possible, the collection can be used endo hard intervention to drainage the collection. And you have to resolve the ball in obstruction. If you don't resolve the ball obstruction, the fistulas will not close. So in this situation, you have first resolve the ball obstruction, draining the area of the fistula if possible or not. Try to avoid to surgical put hands in the esophagus area sometimes in this position, because sometimes you have injuries of the fundus and other sutures in this position. The inflammatory in this area at this moment, sometimes you can make more injuries than you need. Only try to drain and wait. And usually here, this fistula can see in patients who have bariatric surgery, sometimes have these fistulas. They put endoscopic vacuum to aspirate this fistula, this hole in the esophagus, and resolve this injury sometimes. And sometimes you can put a stent to close these injuries and avoid the collection. But sometimes here, the endoscopy using vacuum to dressing vacuum, endoscopic dressing vacuum to correct these fistulas. But first, you have to correct the ball obstruction.
Great. So a little bit in line with Dr. Lenin, who told us about the endoscopic possibilities as well. So Dr. Untracht, you have a small bowel obstruction distal to the jejunostomy, and also this leak. Would you try endoscopic treatment, or would you follow Dr. Cassimi as well as exploration of the abdomen and trying to solve everything in a single surgery?
Well, it has to be the latter. What you have in this case is a lateral fistula. So, and Dr. Coile gave a very good outline of the factors that prevent the lateral fistulas from closing. So you have a distal obstruction. That's first. You have to fix that. So the patient needed to go back to the OR as you did. And then the other reasons, as Dr. Coile said, if you have a big abscess or a big collection associated with the fistula, that has to be drained. And then if it's a mucus line fistula, it's not going to close. That doesn't apply here. And then the other reason that it won't close is if the two ends, if really it's a fistula because the stomach and the esophagus are in two pieces, and it's just a big separation, which doesn't seem to be the case. So really, once you've gone back to the OR, if you've corrected the distal obstruction and you said that the leak was very well drained, I take it you could see the area of the leak and that there was no collection around it, and the leak was well controlled, then that will close with time. The patient will eat some nutrition, give it some time, and it will certainly close. The addition of that intraluminal esophageal suction is just a way to help lower the drainage and keep the area decompressed. That's what, you could use that or not, but I think this is likely to close on its own. Because of your syllabus, it seems like you went ahead and put a stent in place, or now they have these nice clips that the gastroenterologist can put to try and suture the mucosa. I don't think the latter would work. You can't just suture it, but a stent across, probably that's what you did, and it worked. But it would have worked anyway if you didn't use it based on what you did. If you had a good control of the fistula, good drains, good decompression, this is going to close on its own. It's basically a pseudodarviticulum that will just close given some time.
Great. Thank you. Thank you all. Dr. Evelyn, you may continue.
Okay, so as you mentioned, we're in the OR. So the surgeons that went to the OR for the small bowel obstruction, jejunostomy revision, felt that the foregut was well drained and that it would have been more harmful to the patient to re-enter that area. He was already well drained. He wasn't sick from the leak. It was a small leak on the upper GI, and to continue the management of wide drainage and source control that way. Unfortunately, he did get sick within a week's time. I have the timeline on the next slide. And he did get endoscopic surveillance. And at this time, we're starting to see some mucosal necrosis. And there's a Z line I mentioned earlier, where you can see the 1 centimeter defect. This was not amenable to clipping at this time. We did have some advanced endoscopists available to us at this time. They did end up placing this wall flex covered stent in the patient at this time. So this therapy, it does have some data behind it in the trauma world, actually. This is out of Saudi Arabia back in 2020, just a case study where they did manage a posterior gastric leak with gastric stenting, but not a ton of literature in the trauma world. Have you guys ever managed gastric leaks or even esophageal leaks with stenting before?
No, not me. I don't know
Only
if Dr.
after
Untracht?
traumatic injury,
Yeah.
only after endoscopic perforation.
Dr. Untracht, Dr. Lenin, any experience with traumatic injuries? No?
Yeah, we've managed them with stents before. It's not, obviously, a lot of times it's been leaks from a repair.
Yeah.
But there's also been times when delayed injuries have popped up and tried to manage with stent.
Mm-hmm.
Right.
Okay. Okay, Dr. Evelyn?
So the patient undergoes the wall flex stent therapy, and it's even upsized after the patient has persistent sepsis. The white count continues to uprise. He's persistently febrile. We get repeat imaging. He has an increasing left upper quadrant, fluid collection consistent with an abscess. So we abort our understanding that this is a well-drained leak. He has repeat endoscopic surveillance. This is, as I mentioned, he is persistently septic. And now we have 2 defects. So that necrosis, the necrotic mucosa is now lend itself to 2 defects. So in the initial operation, there was quite a bit of bleeding in the area that was managed with clips, and they believe this may have been contributing to the full thickness necrosis that was appreciated endoscopically. And so now that's what we're believing now 14 days later, that why we have 2 defects. So the wall flex stenting has not managed this despite being upsized once. The patient's not tolerating it. It usually remits terrible reflux. He's had an NG tube the whole time. The NG tube and the G tube, both of these tubes for decompression that we tried like the last week of the wall flex stenting. It's just not tolerable to him. Would you abort this therapy, or would you still try to persist with the wall flex stenting? Are there any options that you're aware
of? Dr. Untracht, want to tackle this one?
Well, and now the patient seems to have a large abscess in the septic, so no, you can't. You have to drain the abscess, so you can't proceed with the lesser invasive procedures. You can try and drain the abscess percutaneously, CT guidance, but probably the best way is in the OR, wide drainage, place large sump drains, and if you can see where the hole is, so the hole is in the esophagus, and it depends on how much stomach you've removed, and what the situation is now with all the scarring, but the first option would be to try to close those leaks with a gastric patch or a gastric wrap. It seems just above the GE junction. So that would be the first choice, or the second choice. The first choice, wide drainage, minimize the amount of leakage through those two holes. And again, they still might heal. The fistulae will become controlled and they'll heal. But the second choice would be to try and cover it with tissue. If not stomach, then perhaps a serosal patch or Y limb and a serosal patch. But the patient has to be in better shape. You first have to get control of the sepsis and then see how he does after that. See what happens to the fistula, if it's making progress or not.
Yeah, now that the patient is septic, I think that most of the panelists would go with the idea of surgery. But Dr. Coile, Dr. Francisco Coile, Dr. Lenin, Dr. Kasim, if you have any different thoughts and you want to share.
Well, in my opinion, my teacher, again, there was a gentleman called Dr. Brain. He was at Guy's in London. He told me, when you do esophageal surgery, don't be a chicken nor an ostrich. And he said, you need to be brave, very brave. Otherwise, don't go near the esophagus. Let somebody else do this. And as I said, that this type of injury are prone to giving us problems. So you need to address the complication as vigorously as possible. Now this patient is septic. You have tried the non-invasive measures. It's like it made the problem worse. And drainage has not been very effective. So you're now left to it, taking care of the problem to save the patient's life. Otherwise, sepsis is going to kill him. So you need to go back to the area, and this time you may have to do a thoracoabdominal incision and resect that area and staple each end and rely on feeding through the feeding tube and come back much later to reconstruct the gastrointestinal tract. And that's the only way you're going to save this patient's life. Sorry for being so bold and so aggressive. And like I said, esophageal surgery is not for the chickens.
That's great. Thank you.
I think it's going to be really difficult to get back to that area at 2 weeks.
Yeah, we're
It's gonna
2
be
weeks
really
out.
very
so-
difficult to get back to that area. I mean, if you can percutaneously drain an abscess, maybe that's the best way to go. There's still, I mean, the one other thing you can try with these is an endoscopic vac, where you use a vac on that, and you can use, and it can help heal it. But I would be really, I think it's very dangerous in that area to go back at this point. 2, I think if you go back, you got to staple him off, and then he's gonna be like that for a while. And you probably have to do a spit fistula, and so it's going to be much more morbid. I think obviously I'm not seeing how sick the patient is, and I didn't see the collection, but if it's percutaneously drainable and he's manageable, I may try an endoscopic vac in this situation.
Excellent. Great points. Dr. Evelyn, we have 6 more minutes, so I think you should move on. Yeah.
And I'm so glad you mentioned that, because I had a privilege of working with some very advanced esophageal surgeons in residency, and advanced MIS and bariatric surgeons who did deal a lot with proximal gastric leaks and esophageal cancer patients who had leaks, unfortunately, and they thought outside of the box. And we're not going back at day 14, unfortunately. I think that that would be harmful to the patient, and particularly a 39-year-old, giving him a spit fistula or fistula would be life limiting. So we did think outside the box, and we did, I'm just going to skip to the end, a novel therapy. Novel approach and novel therapy, although you already knew about it, the endovac therapy, not ever written about in the trauma world. But you can place endovac within esophageal leak, distal esophageal leak, and this was very successful in this patient. So we did not go back. We managed this in a 2-week period, and it was completely resolved. To get to the punchline, the novel approach that we utilize is he hated his NG tube. I mentioned that several times. So we actually, rather than this schematic here, we actually utilized his G tube. So what we did was we utilize an NG tube, but you place it through the gastrotomy. So through your standard 20, we upsized him to a 28 French size G tube. When we placed the NG tube through it, we endoscopically grabbed it from the stomach, pulled it up through the mouth, and then just to show you kind of a schematic of how you do it, we wrapped the endovac sponge around it. You suture tie that around it, and then we dragged it back down into the defects where we wanted it. We did an exchange every 3 to 4 days. And then on our surveillance, he was completely cured. So it was a very cool case study of how you can manage a distal gastroesophageal leak with an endovac rather than giving him a fistula or other options. Just to mention, this is the largest study we've had. It came out of LA County, 238 patients, and their 2008 to 2016 case study that they had. 96% were penetrating. Generally, traumatic gastroesophageal injuries are penetrating in nature. They generally have another associated injury that requires an operative exploration. 4% do require an associated thoracotomy at the time, generally male, 25% mortality. So this guy was very fortunate, and 100% generally go to the ICU. So just to cover some epidemiology. And these are all your options, which I think we covered them all today. I'm not sure that I would ever manage this as a first attempt with endovac therapy, but if I had a leak, I'm definitely going to keep this one in my back pocket, as well as all the other things that everyone mentioned today. Thank you so much for your time and all of the wisdom and guidance today.
Dr. Evelyn, what did you do with the right upper quadrant abscess?
I'm so glad you mentioned that. So we not only managed that percutaneously, but we wanted excellent drainage. Those 2 holes, I had a great endoscopist. We did the endoscopy, the endovac placement ourselves, but we also had a very advanced GI specialist, and he was able to actually place one of those little blue drainage tubes right through one of those holes for like a solid week, and we had excellent drainage right into the stomach. So we widely drained 2 ways.
So this was transgastric drainage, but from the inside out, right? Nice. Yeah, nice. Dr. Untracht, any final comments?
Yeah, great case and very innovative, and well done. A good understanding of the pathophysiology, and using good thinking out of the box to get control of it. Well done.
Before I move with the other panelists, there's a quick question here in the chat from Dr. Schneidman. I don't know if I'm pronouncing this correctly, Schneidman, asking, how did you drain the stomach during the time of the retrograde endovac? And how did you feed the patient? Did you switch to a TPN during that time?
We still had that jejunostomy tube that was revised. So he was fed via the jejunostomy tube. And then the G tube was still placed to drainage during, but he just had forward emptying of his stomach. So, but you have the placed to the wound vac. So we didn't have any problems with gastric emptying at that time.
Nice. Dr. Lenin, any final comments?
No, it's great presentation. I mean, I think it's important to present complications. It's not the easiest thing to stand up there and present like your leaks and stuff, but you know, it's important to learn from them, especially because that's really what ends up making you probably a good trauma surgeon. Is, you know, our patients have problems, so learning how to manage the problems is really important.
Thank you.
Yeah, excellent point. Dr. Kasim, any final comments?
Human ingenuity keeps marching on. And this is a good case where alternative to open surgery, somebody came up with the solution for a very, very difficult problem and saved somebody's life. Fantastic. Very good presentation. I learned a lot. Something that I will remember, probably will never do, but I'm sure that my gastroenterologist friends will be excited to learn this technique.
Excellent. Dr. Francisco Coile needed to leave the meeting, but I just wanted to also thank him for being here and as a panelist. I also want to thank Dr. Untrak, Dr. Lenin, Dr. Kasim, and Dr. Varam for their valuable comments. It was a great case. Dr. Evelyn, thank you very much for presenting today. And I guess I'm seeing Dr. Antonio Martos here at the meeting. I don't know, Dr. Antonio, do you want to close the meeting and make any final comments? I don't know if... No, I don't think so. I don't know if he's able to open his mic, maybe. Okay, everyone, thank you very much for being here today in this meeting. It was awesome. And Dr. Evelyn, again, thank you very much for presenting. Once again, if you are watching this meeting and want to present cases as well, just send me an email or send me a WhatsApp so we can arrange for the presentations in the forthcoming weeks. Thank you very much, everyone. I'm going to see you next Monday. We're not going to have meetings on the Mondays before Christmas and before New Year's Eve. So we are coming back after the New Year's Eve with a meeting in the Monday in the 1st January of the month. So once again, thank you very much, everyone. I hope to see you in the next meeting. Bye-bye.